Good morning, good afternoon, and good evening, and welcome to the ISTH webinar, How I Treat Challenging Cases on Thromboprophylaxis for Medically Ill Patients. My name is Marc Carrier. I'm one of the hematologists at the University of Ottawa in Canada, and we have a fantastic panel today to present these challenging cases. The first presenter will be Dr. Lara Roberts, who is a consultant hematologist at King's College Hospital in London, England, and Professor Ingrid Pabinger, which is the previous president of ISTH and hematologist in the Department of Medicine, the Clinical Division of Hematology and Hemostasis at the Medical University of Vienna in Austria. Before starting, we would like to thank our sponsors, Viatris. The learning objectives for today will be really to have a good discussion about challenging cases for decision on thromboprophylaxis, the type and doses of different type of patients admitted to hospital for medical illness. We will have a brief agenda over the next 45 to 50 minutes. I'll do a quick introduction and welcoming comments. Then we'll go right into the challenge with Dr. Roberts. We'll have case studies from Dr. Roberts, Pabinger, and myself, and then we'll have a few minutes for questions and answers at the end. If you would like to ask questions, or if you would like to respond to the different questions we'll be asking through different polls, please enter your questions using the icon on your left-hand side to send to the speakers. The chat between different participants will not be open today, but we'll have a lot of questions for you to answer. And if you could please click on the icon below before answering the questions, that would be greatly appreciated. And we'll do a few tests in order to make sure that you know how it works before we dive into the presentation. So these questions will be left up for 2 to 3 minutes for you to answer. But the first question was, what is your area of primary clinical focus? And then a few questions about your healthcare professional categories. And lastly, we'll ask you some questions in order to try to define your understanding of the content before we start. And we'll ask you the same questions at the end too. So the first question is, which of the following VTE risk assessment tool includes recommendations for prophylaxis? The second question is, you are considering extended thromboprophylaxis with either low-molecular heparin or a direct anticoagulant in medically ill patients being discharged from the hospital. Based on a 2017 meta-analysis by Tao and colleagues, you would expect which of the followings? And lastly, it would be great if you could evaluate the session. So if you can hold up your phone camera to the QR code, the feedback will be very important for us to improve for the next webinars. And without further ado, it's a great pleasure to welcome Dr. Roberts that will bring us up to speed with the challenges for today.
Thank you. It's a pleasure to be here, and thank you all for joining today. So I am going to start by giving a brief overview about the burden of hospital-associated venous thrombosis and the evidence for thromboprophylaxis in medically ill patients. And then I'll discuss some of the guideline recommendations for this patient group and the global uptake of these recommendations. I'll then briefly run through the approach to VTE prevention in England before we move on to the 3 case studies, of which I'll present the first. So we know that venous thromboembolism is common, with an incidence of 1 in 1,000 in adults, and more than half of these events are associated with prior hospitalization. And it's estimated that there's 10 million hospital-associated venous thromboembolic events each year across the world. And we also know that appropriate thromboprophylaxis in selected hospitalized patients is effective in reducing this risk by up to 60%. And in recognition of this, over a decade ago in England and also in the States and other areas, prevention of VTE was recognized as a top clinical priority to improve patient safety whilst in hospital. This is just a brief overview of the VTE prevention pathway at a patient level, but also at a systems level. So it seems like a fairly straightforward approach. We just need to identify patients who are at risk, counsel them about that risk, because we're predominantly using parenteral anticoagulants, which they have to accept. We need to prescribe thromboprophylaxis and then make sure it's administered as prescribed. And there are challenges at each of these steps, which we'll talk through in more detail. So the first step is to identify the patient who's at risk, and that's where the VTE risk assessment comes into play. And the aim of doing a VTE risk assessment is to identify patients who are at high risk so that we minimize the use of anticoagulants in low-risk groups and therefore avoid harm in those patients like bleeding or rarer events like heparin-induced thrombocytopenia. And we also improve cost-effectiveness of providing thromboprophylaxis. It also enables us to select appropriate prophylaxis, particularly in patients who have coexistent bleeding risk factors. But ultimately, the aim is to reduce the incidence of hospital-associated thromboembolism. And there are a number of risk assessment tools available. This is just a few examples of those that are in common use. And I'm not going to go through these in great detail. There is a previous ISTH webinar that was recorded back in 2019, available on the ISTH Academy if you want to go into these in more detail. But essentially the first two, the American College of Chest Physicians and the NHS VTE prevention tool, are quite simple. They're just tick box of various risk factors. And the NHS tool was developed by experts. It hasn't been validated and has been criticised by some for being over-inclusive. It does include bleeding risk factors, and it links directly to a thromboprophylaxis recommendation. Whereas the Padua, Improve and Caprini scores are a little more complex in that you need to calculate a score, but there are now online calculators for all of these. And these have the advantage of being externally validated, but there's only one, the Improve, which incorporates bleeding risk. And they don't directly link to a prophylaxis recommendation. And the VTE prevention guidelines I'm going to talk through in a little more detail are the NICE guidelines, which are produced in England and were last published in 2018. And then the American Society of Haematology guideline published in the same year, specifically looking at medical patients. There are other guidelines available relevant to this patient group, and the ASH guideline does summarise these in contrast with their own recommendations. So if we look first at VTE risk assessment, NICE gives a strong recommendation that all medical patients should be risk assessed at admission or as soon as possible afterwards to identify patients at risk of VTE as well as their bleeding risk. And they recommend using a tool published by a national UK body, which is the NHS tool, or any professional network or in a peer-reviewed journal. ASH, on the other hand, make no specific recommendation, but in the text of the guideline, they make a comment that VTE risk assessment should be integrated into the clinical pathway to improve clinical decision-making regarding thromboprophylaxis. And they specifically review the Improve and Padua risk assessment models. If we look at the evidence for thromboprophylaxis in medically ill patients briefly, these are the landmark studies published now approaching 20 years ago. It's important to note these graphs shouldn't be used to compare agents because the inclusion criteria for the studies as well as the endpoints were different. But the important thing to note is the blue bars represent the intervention, so the anticoagulant prophylaxis, and the red bars are placebo. And you can see that consistently provision of thromboprophylaxis in the graph on the left results in a significant reduction in VTE risk of up to 60%. On the right, we have the major bleeding rates, and again, you can't directly compare these agents due to differences in definitions of endpoints, but you can see that there is a small increase in the absolute risk of bleeding associated with use of anticoagulant prophylaxis. So reviewing these studies and a number of other later studies, which were sort of slightly different in the inclusion criteria, but NICE makes a strong recommendation that patients should be offered pharmacological VTE prophylaxis for a minimum of 7 days where they've been identified to be at high risk of VTE. and that we should use low molecular weight heparin first, and if that's contraindicated, use fondaparinux. And the exception to this would be patients with renal impairment, where either lower dose low molecular weight heparin or unfractionated heparin could be used. And this contrasts to the ASH guidelines, which, reviewing the same evidence, makes a conditional recommendation suggesting the use of any of these agents rather than no anticoagulant for patients who are at high risk of VTE and low bleeding risk, with a preference for low molecular weight heparin or fondaparinux over unfractionated heparin. So there is still some controversy over the evidence and its application. And there is probably partly related to that global variation in practice. So this is taken from a study published earlier this year, undertaken by the World Thrombosis Day subcommittee of ISTH, where all participants at the ISTH 2019 meeting in Melbourne were sent a survey asking about VTE prevention practice in their countries or hospitals, and they had over 200 responses, which they collated by country. This is just a selection. I think they had representation from over 30 countries. But they looked at whether there was a VTE risk assessment model in use, whether that was mandated and what the uptake was in each country, as well as whether there was national VTE guidance. And the grey bar represents no data. There's no red in these ones, but red would be no use and green is 100% use. And there's still significant variation across countries in use of both risk assessment and whether there's national guidance. And there are only 3 countries that reported having a national guideline, of which the UK was one, along with China and Belgium. And I'm highlighting the UK here because we've been fortunate in having a systematic approach implemented in the UK, which I'll talk about shortly. A second study, again led by the World Thrombosis Day subcommittee group, looked at geographical variation in thromboprophylaxis use in acutely ill medical patients. And they undertook a meta-analysis of 27 studies reporting VTE risk and uptake of thromboprophylaxis in those studies. And the most commonly used risk assessment tools in these studies were the ACCP guideline, Padua and Caprini. None of these studies used IMPROVE, but based on patients who were at risk, we're still not offering optimal thromboprophylaxis. So it varied from about 40% up to almost 70% across the globe, but still less than where we'd like it to be. So I'm just going to briefly look at the approach in England, which, as I say, was implemented in 2010 with the overall aim of reducing death and ill health associated with hospital-associated thrombosis, and to also embed VTE prevention into routine care within the hospital. And it was underpinned really by the introduction of mandatory documented VTE risk assessment with central reporting of the risk assessment rates from each hospital, and a financial penalty for failing to achieve the initial target of 90% of all hospitalised adults. And this was supported by the national NICE guidance, which was released at this time. And there was a call to undertake root cause analysis of all episodes of hospital-associated thrombosis and to establish systems both locally and nationally for monitoring of both process and clinical outcomes. So this shows the uptake of VTE risk assessment. So we started risk assessing in early 2010, and July was when we first had to start reporting. And it was less than 50% of patients being risk assessed at the time of initial reporting. And over the next 18 months, we reached the target of 90%, and that was subsequently maintained, with the target increasing to 95% in 2014. And again, that was maintained up until November 2019, which is unfortunately when we last have any data because it was all put on hold with COVID. And we've also recently completed a national survey of thrombosis in 2019-20, which had a number of aims, one of which was to look at provision of appropriate thromboprophylaxis. And we had 98 hospitals, which represents just over 2/3 of the NHS hospitals, provide data on just over 9,000 patients who are in hospital and considered at risk of VTE and the prophylaxis provided. And pleasingly, this showed that overall 88% of patients at risk were receiving appropriate anticoagulant prophylaxis, with not a lot of regional variation, but at individual hospitals it did vary from 40% up to 100%, so there's still some work to do. And the other national measure that we have is from the NHS Outcomes Framework, where each year they publish deaths from VTE occurring within 90 days of hospital discharge. And again, over the reporting period, we've seen a 16% reduction in post-discharge VTE deaths. So just to summarise this bit, there's data that thromboprophylaxis is both safe and effective in reducing hospital-associated VTE. But despite this, there's still significant gaps in implementation of VTE prevention practice globally. But I think the approach in England demonstrates that this can improve uptake at a national level. So I'm going to move now on to the first of our challenging cases, which is focused on obesity as a risk factor for venous thrombosis. And this is a growing problem. We know in Europe in 2013, over 20% of people were obese, and worldwide in 2016, the WHO published data demonstrating that 13% of adults were obese, and we anticipate these numbers will continue to rise. And we know that obesity is a risk factor for VTE. This is a meta-analysis performed some time ago showing that a BMI of over 30 kilograms per meter squared increases the risk of VTE twofold. So the case we're going to discuss is a 51-year-old gentleman who came in with pleuritic chest pain and a productive cough. He was found to have reduced air entry and crepitations at the right base. He had a leukocytosis, raised inflammatory markers, and a mild hyponatremia, and his chest X-ray demonstrated right basal consolidation. He was weighed on admission. His weight was 131 kilos. His BMI was 43 kilograms per meter squared. And he needed hospital admission for intravenous antibiotics. So we have another poll now. If you go to that section, the question is, which of the following patient-related risk factors apply to this patient? And you can choose more than one option here. And the second question is, based on those risk factors, is thromboprophylaxis indicated? So if we look at the various risk assessment tools, first using the NHS national tool, this is just a tick box where any tick in any of these risk factor boxes would indicate a high risk of VTE. And this patient has 3. He's obese, he has an acute underlying infection, and he's anticipated to remain immobile for 3 days or more. The bleeding risk assessment again just asks whether any of these bleeding risk factors are present, and he has no bleeding risk factors. So he would be considered for thromboprophylaxis in England. If we look at the improved risk score, shown here in the table, this gentleman, unless on admission he's thought likely to be immobile for a week or more, he has no risk factors, but even with that risk factor, he still wouldn't qualify for thromboprophylaxis, where a score less than 2 is associated with an incidence of VTE of less than 1% without thromboprophylaxis. And if we look at the Padua score, which was also discussed in the ASH guideline, he would score points for reduced mobility and obesity and acute infection, and a score of greater than 4 in the validation studies was associated with a VTE risk of 11%, so thromboprophylaxis would be considered appropriate. And I think in the poll for the previous one, should he receive thromboprophylaxis, 95% of you said yes. So in that case, the next question, again in the polls, is what dose should we give? So again, you can indicate your answer while I carry on. So if we go back to the guidelines, NICE had a review question asking what the effectiveness of weight-based dose-adjusted low molecular weight heparin was compared to fixed doses. And they found no relevant clinical studies and did not make a recommendation. This wasn't considered by the ASH guidance. This was previously considered by the ACCP guideline, where they recommended using weight-based adjusted dosing in patients undergoing bariatric surgery. but made no specific recommendation for other patient groups or how to dose adjust. So why might we want to think about dose adjusting? If we look at the pharmacokinetics of low molecular weight heparin, obesity doesn't impact on its absorption. The volume of distribution of low molecular weight heparin is virtually entirely intravascular, so it's determined by plasma volume, which again is not significantly increased with obesity. And its clearance is almost entirely by renal elimination, and that is impacted on by obesity. So this graph was produced by Han and colleagues to describe the relationship between renal clearance and lean body weight, and that's shown by the solid line, and the clearance is the dotted line, and they increase in parallel, particularly with a BMI of over 30. So if we think about fixed dose versus weight-based dosing for treatment of VTE, most of the product licenses suggest dose capping at high body weights. And this has largely come about to these patients being excluded in the seminal studies of drugs. And there have subsequently been case series and other reports suggesting that this practice might lead to increased morbidity in patients at increased body weight. But we don't know for certain whether fixed dosing is adequate for thromboprophylaxis. And the other challenge on sort of a practical aspect is that you need an accurate patient weight on hospital admission to even be able to consider whether you should be increasing dosing. And this has been highlighted through national patient safety alerts in England as well. So if we look at thromboprophylaxis studies in obese patients, they're predominantly performed in patients undergoing bariatric surgery, and they're largely observational with a single very small randomized controlled trial. They all use surrogate markers for efficacy, and they predominantly use peak anti-10A activity, which, if we're concerned about increased clearance, might not be the optimal measure, along with not actually knowing what or how anti-10A levels correlate with clinical outcomes. There are only 3 very small studies of enoxaparin in medical inpatients, again using peak anti-10A activity. And there was 1 study in trauma patients using trough anti-10A activity. So it's fairly low quality evidence to support changing the dose. There was a post-hoc analysis of the PREVENT study, which is the seminal study looking at dolteparin versus placebo. And they looked at the impact of BMI on efficacy. You can see there are only 3.3% of patients with a BMI over 40, so that was just over 100 of their patient group. But in that BMI band, there doesn't seem to be as much of an effect in reducing VTE, which might suggest that increasing the dose would be a benefit. So in England, despite there not being a recommendation by NICE from the National Thrombosis Survey, of the participating hospitals, 82% use weight-based dosing for thromboprophylaxis. So again, we've got another poll asking you to consider the options for thromboprophylaxis and what you would give this patient. I think most of you said to the previous response that you would use weight-based dosing. So in this case, the patient improves with IV antibiotics, and he's planned to go home following 4 days of admission. So the next poll question is there a role for post-discharge thromboprophylaxis? And again, you can continue to answer while I speak. So again, there's data that suggests that most VTE associated with hospitalization occurs in the post-discharge period, following both medical and surgical admissions, mostly in the first 30 days, but the risk is increased out to 90 days and marginally thereafter. So if we look again at the guideline recommendations, NICE gives a strong recommendation that patients should receive a minimum of 7 days thromboprophylaxis. ASH gives a strong recommendation for inpatient only over inpatient plus extended outpatient VTE prophylaxis. So the NICE recommendation was based on those seminal studies where the median length of stay was 7 days. And if we look at the PREVENT trial, which is the dolteparin versus placebo study as an example, they did continue low molecular weight heparin even post-discharge. So all patients on the treatment arm received 14 days of dalteparin. But the eligibility criteria for this study were quite strict in that you had to be over 40, immobilized for at least 3 days, and have a predicted length of stay of at least 4 days, and have either cardiac or respiratory failure. Or if you didn't have those two conditions, you needed to have 2 risk factors, like acute infection, like this patient, and one other, like obesity. So he may have made it into the study if they thought he was going to stay longer than 4 days at presentation. But if he was thought to go home quicker, he might not have. And in England now, the median length of stay 20 years later is 3 days. So we're treating people and getting them out much quicker. And we would offer thromboprophylaxis to patients with a much lower risk factor profile, so having just one of these risk factors. So the NICE guideline created a bit of contention when it was released, and there were bodies such as the British Society of Haematology questioning this decision-making and raising concerns, particularly about the practicalities of administering low molecular weight heparin in the post-discharge setting, and not only the drug costs, but potentially district nurse costs for those patients unable to self-administer. This is a meta-analysis looking at the role of extended thromboprophylaxis using low-dose direct oral anticoagulants compared to inpatient or in-hospital enoxaparin only. And you can see that those patients who received low-dose direct oral anticoagulant, which continued for up to 6 weeks, did have a reduced risk of VTE. But on this bottom plot, we have total bleeding events, and the patients who received extended direct oral anticoagulant had a nearly 2-fold increase in bleeding events. So putting that into context, the overall rates of symptomatic VTE were relatively low compared to those initial landmark studies. Again, the endpoints were different. But in the in-hospital only low molecular weight heparin group, 1.7% had VTE compared to 1.1% receiving extended direct oral anticoagulant. So to prevent one of these events, you'd have to treat 176 patients. Whereas the bleeding rates were higher at 3% in the in-hospital only low molecular weight heparin group and almost 5% in the direct oral anticoagulant group. So the number needed to harm one patient is 60. So the risk-benefit doesn't favour extended anticoagulation. So again, looking at the uptake of the NICE guidance recommending a minimum of 7 days, there was a survey of our VTE exemplar network hospitals. It's a group of 25 hospitals who sort of been awarded this exemplar status in recognition of their excellent VTE prevention care. 96% of them did not implement this recommendation. And in the National Thrombosis Survey, of those 98 participating hospitals, more than 85% were not offering a minimum of 7 days. So in this case, he wasn't offered post-discharge thromboprophylaxis. One of the other metrics in England is that all patients should receive information about their risk of VTE on admission and hospital discharge. And this is incorporated into the discharge summary, where they're given another reminder of the symptoms to look out for, which is also important because we want these patients to present early if they do develop post-discharge VTE.
Thank you very much, Dr. Roberts, for a wonderful presentation and sharing invaluable insight with us today. And we'll move to the second presenter, Dr. Pabinger, who will also present us a challenging case in the setting of cancer-associated thrombocytopenia.
Thank you, Mark. Ladies and gentlemen, good morning, good afternoon, and good evening from Vienna in Austria. So I'm going to talk about cancer, a cancer patient, and the burden of venous thromboembolism in cancer. So cancer itself is already a big burden for a patient. And there is the additional scare of comorbidities. And venous thromboembolism is one of those very important comorbidities that are also, they increase the mortality and the morbidity. So what do we know about cancer and epidemiology? Quite a lot. And we now know that overall cancer accounts for an estimate of 18% of the total number of VTE cases. And this is specifically the case in patients that are 60 years or older. And based on hospitalization rates for venous thromboembolism, the incidence rate for cancer-associated VTE was estimated to be 8 per 1,000 patients per year. And there is a very big range with regard to incidence of thrombosis in patients with cancer. Between 0.5 and up to 20% suffer a VTE event per year. And the risk is dependent on various aspects, and we will cover that with our case. So this is one figure that has been or is often shown, but it very clearly shows the risk over the course of disease in a cancer patient. At diagnosis and during the initial hospitalization, the risk is very high. We know that the risk is highest within the first 3 to 6 months after a cancer diagnosis, and specifically during hospitalization. When there is effective treatment and effective chemotherapy and the patient is in remission, the risk is lower, but rises again when there is recurrence of disease, also when there is more extended disease, metastasis, and is very high at the end of life. So let's go to our patient. This is the baseline information. A 61-year-old woman, and she has metastatic pancreatic cancer. She is not overweight, so her body mass index is 21.5, and she also has no personal or family history of venous thromboembolism. And she is in good general health condition, but she feels tired, and most time during her admission at the hospital, she is in bed, and her ECOG status is 1. As she is in a good condition, she is planned to receive FOLFIRINOX, a very aggressive chemotherapeutic regimen, and this is planned to start during the hospital admission. Well, when we talk about risks in cancer patient, the most important risk factor is the cancer site. And there have many studies been published on that. And in almost each of the studies, pancreatic cancer was the cancer site with the highest risk. You can see here, after half year, approximately 20% incidence, and after 2 years, more than 30% incidence of venous thromboembolism in patients with pancreatic cancer. Also high risk site is gastric cancer and also brain, specifically glioblastoma. And interestingly, the risk is lower in breast and prostate cancer patients, and intermediate in lung, lymphoma, and colorectal cancer. So our next question, or the question to you, is: should the patient receive thromboprophylaxis during her hospital stay? And we have these answers, A to E, and I ask you to answer now. So would you just suggest that the patient should wear compression stockings, or would you give the patient direct oral anticoagulants or no thromboprophylaxis or thromboprophylaxis with low molecular weight heparin, or because she has pancreatic cancer, use higher doses, therapeutic doses of low molecular weight heparin. You have now several seconds to answer these questions. I cannot see how many answered the questions, but I think we can stop the poll and go through these questions. Well, compression stockings is not suggested as the only thromboprophylaxis in cancer patients. And here I also have to say that we have no specific studies in medical oncology patients. Lara mentioned the studies in medically ill patients, but there are no specific studies in those patients. Well, with regard to thromboprophylaxis with a direct oral anticoagulant, this is also not the primary thromboprophylaxis that we would suggest. We could think about direct oral anticoagulants when we already think about ambulatory thromboprophylaxis. We will then also see it at the guidelines. Well, no thromboprophylaxis could be a suggestion that you think the patient is not in bed, is walking around, and that her thrombosis risk during that hospital stay is not so high. However, we mentioned that most of the time she is in bed. Well, thromboprophylaxis with low molecular weight heparin would be suggested as a prophylaxis in that patient, and definitely not therapeutic doses of low molecular weight heparin, because the patient does not have does not have acute venous thromboembolism. So next, I would like to look at a guideline selections here. The American Society of Hematology suggests with low evidence and as conditional recommendation thromboprophylaxis over none and low molecular weight heparin over mechanical. Mechanical only be used in patients that have a high bleeding risk. And the International Initiative on Thrombosis and Cancer recommends low molecular weight heparin or fondaparinux in those with decreased mobility, and DOACs are not recommended. Well, the patient is now going to leave the hospital. And now we have to decide whether we should suggest thromboprophylaxis after hospital stay. And in principle, and this is also the unique opinion of the guidelines, prophylaxis should be discontinued after discharge. But this patient has a cancer type, pancreatic cancer, with a very high risk of venous thromboembolism. So how could you assess the individual risk of thrombosis in that very specific patient? What can help you? You can take the Corona score, then you need the blood count analysis. In that patient, the hemoglobin is slightly decreased, 11. The white blood cell count is slightly increased, and the platelet count is normal. The dimer that was taken to evaluate the Vienna CAT score is taken, but the patient has no symptoms of deep vein thrombosis or pulmonary embolism. Having these variables, the Corona score is 3, 2 points for the pancreatic carcinoma and 1 for the leukocytosis, where you have the cutoff of 11,000. So Corona score of 3 is indeed a high risk. And in the Vienna CAT score that you can calculate, where you can calculate an individual risk, the risk would be 15 50% within 6 months. So next I'm asking this your patient, what would be your recommendation? Would you suggest thromboprophylaxis with a direct anticoagulant, for example, apixaban, 2.5 milligram twice a day, or aspirin, or thromboprophylaxis with low molecular weight heparin, or no thrombosis prophylaxis, or thromboprophylaxis with edoxaban? And you have time to answer those questions. I think we can end the poll. I cannot see the answers. However, I will discuss the answers. To give thromboprophylaxis with a direct oral anticoagulant is supported by 2 interventional trials. One was first authored and presented at ASH and then published in the New England Journal of Medicine by our chair, Marc Carrier, where apixaban was compared with placebo. And there is another study presented by Alok Khorana and also published in the New England, rivaroxaban 10 milligram versus placebo. And there was a decrease of thrombosis risk by about half, and a slightly increased risk of bleeding. Well, this would be what has also been suggested by the guidelines to give direct oral anticoagulants in patients with a high or intermediate risk of thrombosis. Aspirin is not an option in that patient. It could be an option in a myeloma patient that has chemotherapy, immune modulatory drugs, and corticosteroids. You could also, and this could be one option, give thromboprophylaxis with low molecular weight heparin in a prophylactic dosage. No thromboprophylaxis is at present not advised, and you should not give therapeutic doses in a patient for primary thromboprophylaxis. So last answer would not be a recommendation for your patient. Now we go on with our case report. After 4 cycles of chemotherapy, the patient is readmitted. She has fever. Most of the day she is in bed with no active bleeding. And her laboratory values are really not good. Anemia, decreased white blood cell count, decreased granulocyte count, and also decrease of platelet count, just below 50,000. And we do not have interventional trials whether or not to give thrombosis prophylaxis in patients with thrombocytopenia. However, most physicians agree on thromboprophylaxis in patients more than 50,000, and there is a big uncertainty in patients below, and 20 to 50,000. So recently there was a German, Austrian, Swiss Society of Oncology and Thrombosis consensus, and these are the recommendations. Recommend against thrombosis prophylaxis in patients with very low platelet counts, and pharmacologic thrombose prophylaxis may be considered if platelet counts are between 25 and 50 giga per liter, and can be recommended above 50 giga per liter. And my suggestion for this patient would that she should receive thromboprophylaxis in a prophylactic doses with low molecular weight heparin. But we should frequently monitor the platelet count and clinical signs of bleeding. Now, I think we come to the next case.
Thank you so much, Dr. Pabinger, for such an insightful presentation. I'll take a few minutes really just to have a quick look at another case that is controversial and for which we've been managing different waves during the COVID pandemic and trying to provide some insights on new data before we go into the rounds of questions. So this is a 59-year-old male, past medical history of smoking, not vaccinated against COVID-19, presented to the emergency room with fever, cough, progressive shortness of breath, generalized fatigue. He is positive with PCR testing for COVID-19. He has some O2 requirements requiring 4 liters per nasal cannula. He does have reasonable complete blood count parameters. His coagulation parameters are normal. His platelets is slightly on the lower side, but still within normal range, and he has a elevated D dimer. He has good renal and liver function. The next question is, this patient will need to be admitted on your COVID ward for medical illness. Should this patient receive thromboprophylaxis or not? And, after reviewing Dr. Roberts and Dr. Pabinger's cases, I think you would probably agree that this patient should probably receive some form of thromboprophylaxis. And therefore, the next question after that is, if so, what agent and at what dose should be receiving prophylactic dosing of fractionated heparin or low molecular weight heparin, should be receiving prophylactic dosing of DOAC, intermediate dosing, or therapeutic dosing of low molecular weight heparin and fractionated heparin, or a direct oral anticoagulant. There's lots of data that has been happening over the last year or so, and we'll try to summarize that briefly for you. So there's no doubt that when we go back in time, spring of 2020, there was a lot of initial reports initiating or planting the seed that COVID-19 may be associated with coagulopathy. Early reports from China looking at D-dimer really provided some insight that there was a way to stratify patients according to their overall prognosis, and higher D-dimer seemed to be associated with worse prognosis and increased morbidity, really planting the seed that it might be associated with a higher risk of venous thromboembolic and, to a certain degree, arterial thromboembolic complications. This slide that was presented or published in RPTH in 2020 is now dated, of course, but really highlights and shows the wide range of the different rates of VTE in hospitalized patients with COVID-19, both admitted to hospital wards and the critical care unit. What is really clear about this figure, and what I like to highlight, is the incidence of VTE is quite different depending on the use of screening imaging for asymptomatic patients. But when you have an overall look, the overall incidence was 14%, so higher than what we would expect for these patients. Obviously, lots of limitation, small studies, high likelihood of bias, differences in challenges in diagnosis. Some people underwent screening with ultrasound, others not. Some were symptomatic, others not. Different definitions of VTE, including proximal or distal DVTs, for example. Different prophylaxis strategies. Early on, some people receive or not thromboprophylaxis, and different dosing from prophylactic to intermediate to therapeutic dosing. But nonetheless, it looks like there's an increased risk of venous thromboembolic complication for COVID-19 patients that are admitted to hospital. And therefore, it leads to an understanding that maybe thromboprophylaxis is important, and begs the question, what type and dose of thromboprophylaxis? With laboratory and clinical evidence of a prothrombotic state, as we mentioned, the concept of immunothrombosis emerged, which is characterized by the immune-mediated activation of prothrombotic pathways leading to systemic deposition of thrombi within the blood vessels of the lungs, the liver, the heart, and kidneys, and really led to a lot of different clinical trials suggesting that maybe there's a role for anticoagulation to decrease morbidity and mortality of COVID-19 that is beyond preventing or treating venous thromboembolic disease. So a number of randomized controlled trials have looked at different type and dosing of thromboprophylaxis regimen. And these are the 3 trials that were published over the last year. The multi-platform trial, a collaboration that was international, including 2,200 patients, comparing usual versus therapeutic dosing of low molecular weight heparin or fractionated heparin. The rapid COVID trial, another international collaboration comparing prophylactic to therapeutic dosing of low-molecular weight heparin, fractionated heparin, and the most recent one, the Hep COVID, that really looked at patients with COVID-19 at a slightly higher risk, maybe a VTE with D-dimer levels, or a sepsis-induced coagulopathy score of more or equal to 4, and then comparing again different dosing of low-molecular weight heparin and fractionated heparin. These had different primary outcome measures. Some of them were venous thromboembolic complication or thrombotic complications, but others went beyond that as well with the immunotherapy prothrombotic state in mind and looked at other ways to look or assess thromboprophylactic dosing in the setting of acute medically ill patients requiring hospitalization for COVID-19. So when you put all these 3 RCTs together, it's including over 2,800 folks. Admittedly, there's some limitation, different waves, there's some different countries, different practices. But when you look at the pooled result of all-cause death, this seems to be associated with a non-statistically significant decrease in overall mortality. They've shown significant reduction in death or mechanical ventilation, death or organ support, death or major thromboembolic event, or overall major thrombotic event as well. There is significant increase in ventilation-free days. Again, thinking about the immune-mediated activation of prothrombic pathways, so looking again beyond just the VTE-related primary outcome measures, and also an increase in organ support-free days. That came at a cost, with a non-significant increase in major bleeding as well. So how do we incorporate that into clinical practice? Very recently, clinical practice guidelines have re-looked at the data, and they're suggesting that we should use some form of thromboprophylaxis for hospitalized acutely ill patients with COVID-19. The dose of thromboprophylaxis is still controversial, but based on the data that we're just presented, there's some conditional recommendations. So careful recommendation, meaning that clinicians like you and I really need to look at the risk-benefit ratio of dosing of thromboprophylaxis in that setting. The American Society of Hematology is suggesting therapeutic intensity over prophylactic intensity based on the data we just discussed. The NICE guidelines are also recommending some form of thromboprophylaxis for sure, and a conditional recommendation of a treatment dose of low-molecular weight heparin for young people that don't need high flow oxygen, that are at low risk of bleeding. Again, making sure that clinicians really do a good risk-benefit ratio to avoid any adverse event with therapeutic dosing of anticoagulation. And just last week, or very recently, the ACCP also recommended something in the same lines, a conditional recommendation that was upgraded from the previous recommendation that in acutely ill hospitalized patients with COVID-19 who are at low risk of bleeding, so there's a lot of details in the fine prints, consideration of a therapeutic dose over the current standard dosing was recommended. So if we go back to our case, our 59-year-old gentleman is on low flow oxygen, is a young patient, not at high risk of bleeding, and based on the data that we just looked at, it was decided to start him on therapeutic dosing of low-molecular weight heparin for thromboprophylaxis. So really briefly, just to finish off, because we wanted to make sure that we included some of the controversial issues in our presentation today. The VTE is common among hospitalized patients with COVID-19. In acutely ill hospitalized patients with COVID-19 that are not in the ICU setting, not on high flow oxygen, not in the critical care unit, therapeutic dose may be considered because it seems to be associated with an overall net benefit compared to prophylactic dosing. However, there's still a lot of uncertainties. You need to do a good risk-benefit ratio to avoid bleeding complication. It's still unclear about the mechanism, so undergoing work on that. And there's always the question about generalizability of findings, so a case-by-case discussion is probably desirable. So we'll go back to the question we asked you right before starting to see if there was any difference, or if you have a better understanding of the topic. So remember, we ask you which of the following VTE risk assessment tools includes recommendation for thromboprophylaxis. We'll leave these questions open so that you can provide some answers. The second question was, you are considering extended thromboprophylaxis with either low-molecular weight heparin or direct anticoagulant in medically ill patients being discharged from the hospital. based on the 2017 meta-analysis by Tao and colleagues, you would expect. You have the different potential options. And please, again, evaluate this session so that we can do better. And without further ado, I'll ask both of our presentation presenters one question. We had a number of different questions. Because of time, I'll only ask one to each. But if you have any additional questions, please feel free to contact us. It'll be a pleasure to answer your questions by email. The first question for you, Dr. Roberts. We are seeing an increasing number of patients above 150 kilogram with regards to low molecular weight heparin dosing in patients who, in these patients, would you advocate doses as high as 60 milligrams of enoxaparin or 7,500 of dalteparin BID?
Yes, so at our centre we use enoxaparin, and we actually use once daily dosing unless they're high bleeding risk, and we'd give 120 milligrams for over 150 kilos. But I agree the doses suggested for dalteparin would be appropriate as well.
Fantastic. Thank you so much. And Dr. Pabinger, we have a couple of questions for you specifically. In the setting of an outpatient, you briefly touched on that, but in the setting of a pancreatic patient being treated as an outpatient receiving chemotherapy, you seem to recommend primary thromboprophylaxis. The question is, if you do, how long would you treat this patient for? 180 days, or would you stop once the chemotherapy is finishing, or would you continue beyond that if they're still ongoing FOLFIRINOX, for example, chemotherapy?
Mm-hmm. With regard to the DOAC trials, we have 6 months. So I would suggest 6 months in a pancreatic cancer patient because the risk is highest in the first 6 months. So I would rather go in for that for a period of 6 months in a pancreatic cancer patient.
Fantastic. Thank you so much. And maybe one last question. There was a question about COVID-19 recommendations for ICU patients or patients requiring high flow oxygen or are critically ill. So the recommendations, because of time, we couldn't go through them all, but the recommendation would be standard thromboprophylaxis in that setting based on ASHA and ACCP updated recommendations based on the data that was presented over the past year or so. So without further ado, Professor Roberts, Professor Pabinger, and our sponsor, VTS, thank you so much for your time this morning. It was a fantastic presentation, lots of really insightful comments that I will incorporate in my daily practice. I thank you for your time, and thank you for the audience for great participation in the polls and through the questions. Have a great day.